Psychiatric Society.
Yeah.
Indian Psychiatric Society, the dignitaries are here. So from, say, IPS Professor O.P. Singh is here, Dr. Arvind Brahma is here, Dr. Aleem Siddiqui is here. Our seniors like Dr. Sudhir Bhave, Dr. Nimit Desai sir is here. I pass on this mic to Dr. Ashish Srivastav. He is our chairperson of this psychopharmacological subspecialty. And sir, please take over and start the proceedings.
Thank you, Dr. Vipul. I welcome today evening everybody on this first program of our subcommittee of specialty section. And we promise that we will make it interesting and we'll present to you the best in the fields. And one of the leading examples is Dr. Venkat today, who is our special faculty today. And before we start, since it is the first thing, we would request our office bearers of the IPS to give us a few words of encouragement. I think our president, Dr. Vinay, is not well, and our vice president, Dr. Rathi, is traveling. So they may join a little later if possible, then we will request them to. And to start then, Dr. Arvinda, can we request you to please say a few words for us?
Thank you very much. IPS Psychopharmacology Specialty Section is always a very important committee of Indian Psychiatric Society. And this time you have a wonderful team, Dr. Rajesh Dume sir, and then Dr. Vipul, my dear friend, Dr. Ashish, and Nikhilesh is also there from Bengal. So what the way you are going to start this case series, and today we have a discussion on schizophrenia, and Dr. Venkat is the speaker. I think he's the best person to speak on this particular issue, because for schizophrenia, we know that's it's a chronic illness, and we know that it affects the functioning and quality of life of our patients. And it is also known that we treat schizophrenia every day. We can manage the positive symptoms, but regarding the cognitive dysfunction or regarding the negative symptoms, till that we doesn't have much option in our hands. So, and now we have also third generation antipsychotics also. So I think Dr. Venkat will address all these issues that from clinical point of view, especially me being a private practitioner, I am always interested to learn what is helpful for the clinical point of view. So without wasting much time, once again, I am really thankful to the IPS Psychopharmacology subsection for inviting me and starting this wonderful CME. Over to you, Dr.
Thank you, Dr. Arvinda. He's our honorary secretary of the society, and he's always there. Whenever I've called him, he has always facilitated us to do our proceedings. Now I'd request Dr. O.P. Singh, sir, to say a few words, our editor of the society.
Good evening to everybody. I will not take much time. Of course, the committee with Rajesh Dhume and the DC coordinator Sahul, you, Dr. Ashish Srivastav, Nikhilesh, and Dr. Vipul has started with wonderfully with Dr. Venkat. And of course, there is Sandeep Grover and Sahul again to put what we call the spice on the icing on the cake, rather. Or we saw the tadka lagayenge. So,
Ashish, I must congratulate Shahul for this beautiful logo he has created. I saw in your close group. That is really wonderful, Shahul.
Thank you, sir. And Shahul has taken the lead to do it.
Thank you.
Thank you so much.
Thank you, sir. Thank you, sir. I would request now Dr. Aleem Bhai to say a few words.
Thank you, Ashish boss. Thank you, sir. Thank you, sir. All the names have already been taken, so I'll not repeat them. Just one thing, that psychopharmacology section could also be named our bread and butter section, because this is what we are doing day in, day out. Most important thing, most important program, and a very good person, Venkat boss, to speak here. So not coming between him and the audience. Over to you, Dr. Ashish.
Thank you, Dr. Aleem. I think very eminently, Dr. Sandeep is also among us, Sandeep Grover, and he's the chairperson for the publications subcommittee of IPS. And
Ashish, I think let's not waste time. Let's
no,
give
I'm not asking you.
Venkat.
I will get you, we'll request you to come in after the Dr. Venkat's talk. Okay.
Sure.
So Dr. Tyagi, it's over to you to take it forward. Thank you.
Thank you, Dr. Ashish. I would like to share the screen so that we introduce formally Professor Venkat, though there is no one who does not know Professor Venkat and his genius. Professor Venkatsubramaniam Ganeshan, he is professor at NIMHANS, Bangalore, and he has got his heart at the right place. He is a clinician by heart and a researcher by mind, and a wonderful human being. And that's why he has interest to learn the science that will facilitate a personalized approach to understand and treat severe mental disorders like schizophrenia. And for that, he is leading an individualized schizophrenia treatment and reintegration program, INSTAR program at NIMHANS. Professor Venkatsubramaniam has got another area of his interest, that is neuromodulatory interventions in psychiatry. He is making us wiser with his program, Weak Intensity Stimulation for Enhancement and Reintegration. I have heard him recently on this. It is about studies on transcranial electrical stimulation techniques in psychiatry. And Dr. Venkat, that was a wonderful experience. Thank you. It was a few weeks back at KGMC that I heard you. And he has got more than 400 research publications. He's an elected fellow of the National Science Academies and National Academy of Medical Sciences. The Council of Scientific and Industrial Research has awarded him for his medical research Shanti Swarup Bhatnagar Prize in 2018. And for your genius, sir, it is just an award, and there are more to follow. We are sure of it. And our fraternity is grateful that you have accepted our offer to be a speaker on this topic. So over to you, Professor Venkat. And I request, say all the participants, there are more than approximately 150 already, say that whatever questions they have in their mind, they keep writing in the chat box. Dr. Shahul Amin and myself would be looking into those chat box and would be asking those questions later on. After, say, Professor Venkat's presentation is over, we'll ask Dr. Sandeep Grover to have his words, a few words, and then we'll have those questions in the chat box. Thank you. Over to you, Professor Venkat.
Yeah. Thank you. Thank you, sir, for this opportunity and the generous introduction. And I must mention that many of the awards and recognitions happen because I happen to be lucky to have been at the right place at the right time. So, and thanks to several of my teachers, colleagues, and students from whom I have learned and I continue to learn, and I look forward to learn through interaction in this presentation as well. So thank you, sir. And so the context has been set by several of the eminent faculty that spoke earlier in terms of looking at the treatment of schizophrenia. And I intend to emphasize on some select aspects and briefly touch upon future directions. We are aware that schizophrenia is a complex, multifactorial clinical disorder with a gene come environmental impact. And it has a striking invariance in terms of its prevalence throughout the world. And the baffling aspect of this disorder is its varied course and outcome. And we are also aware that there are several factors, starting from the in utero genetic as well as the prenatal insults, going on towards social and other environmental impact in terms of stressors, including drug abuse, so on and so forth, leading to the onset of the first episode, and which then goes on into a relapsing and remitting course of this disorder. And this disorder is also associated with a lot of brain-related abnormalities in terms of the formation, reorganization, and brain upkeep. So this is a summary slide which crystallizes the biology behind this disorder. And to take half a minute in terms of understanding the neurotransmitter basis, which is directly relevant for the the psychopharmacology, if you look at the summary theory, of course, this is not without controversy, but some kind of consensus. The disorder is associated with abnormal glutamatergic receptors in the cortical GABA neurons, because of which there is a glutamatergic overdrive, which differentially modulates the dopaminergic neuron. At one level, we have the limbic dopaminergic circuit, which is hyperactive. On the other hand, there is also a mesocortical circuit, which is hypoactive. So the hypoactive mesocortical circuit is responsible for the negative symptoms, and the hyperactive limbic circuit is responsible for the positive symptoms. And the dopamine is the primary neurotransmitter, which is of target with relevance to most of the available antipsychotics. Now, we are also aware of an excellent guideline that is published by Dr. Grover and colleagues. I'll just take us through briefly as a recap, which basically emphasizes some of the critical aspects in terms of the assessments that are required to make a diagnosis of schizophrenia, and comprehensive multimodal investigations that will help us to understand the systemic aspects of the patient in terms of helping us to choose the right medications. And also there are indications when to consider inpatient care in terms of unmanageable symptoms that may result in suicidal behavior or severe agitation, catatonia, and so on and so forth. And then there is an excellent algorithm which is given in this guideline where how to approach when people with schizophrenia present with psychosis. We have to look at various differential diagnoses, and then a summary table of the assessments that I briefly touched upon in the earlier couple of slides. And then we have a decision tree which will help us to decide about the treatment setting and then choose the available options. As rightly pointed out by one of our faculty earlier, the pharmacological management, of course, it was mentioned as bread and butter, is the sheet anchor. This is the primary mode with which we treat people with schizophrenia. And of course, in situations which are very challenging, we have interventions like electroconvulsive therapy. And we also have a host of psychological and social interventions, which will also help as supplementary interventions, especially in the initial phase of the disorder. But at the chronic and in select instances of persisting symptoms, some of these psychological and social interventions may become as much important as medications. And in terms of the medications, we have several groups of medications, starting from the mainstay antipsychotics towards adjuvant other medications. And then there are a host of factors which will influence the selection of antipsychotics. And we have an excellent summary of the recommended therapeutic dose of both oral as well as depot medications. And then how to go on further in terms of sequentially progressing with respect to the treatment approach while handling this challenging disorder. And we all know that in terms of non-responding treatment-resistant patient, there is a role for clozapine. And also the guideline touches briefly upon the role of ECT and the indications where one would consider ECT as the predominant mode of intervention. And it also aptly summarizes the critical components of psychoeducation. So this is a guideline which was published about 6 years before, and most of the components of this guideline hold very true in terms of its utility in contemporary clinical practice. So in that context, I thought of revisiting the evidence base that has been emerging, especially over the past decade, that has influenced this CPG, our Indian Psychiatric Society CPG, published by Dr. Grover and colleagues. And then we can also look at what are all the questions that we need to address in times to come. Now, if you look at the antipsychotics availability and its utility, there is always this question of whether we should choose first or second generation antipsychotic. So if you look at some of the major recommendation sources, say for instance, the Maudsley prescription guidelines, the consensus statement is if the extrapyramidal symptoms could be minimized by careful dosing and anticholinergic use is avoided, there's no convincing evidence to support any efficacy advantage for second generation antipsychotics over the first generation. So this is a kind of area where a lot of contra reviews exist. There are studies that show that second generations might be better than first generation. There is also cost consideration. May not be so much in a country like ours, at least for some of the second generation medication, but for many other countries. But this is one view which predominates, and so there is a merit in always having this option of first generation antipsychotics as a consideration. But the reason why we are tilted towards using second generation antipsychotics is perhaps because of the therapeutic index, because an essential difference between these two groups of antipsychotics is the therapeutic index. In the sense, haloperidol has an extremely narrow therapeutic index. Sometimes it could be as narrow as 0.5 milligram. That is a 0.5 milligram difference. Say, for instance, when we are using haloperidol at, say, 3 and then increase it to a little higher than that, say 5, we may end up with more extrapyramidal symptoms. Whereas medications like olanzapine, they have a wide therapeutic index. So the margin of error could be a little larger, especially in busy clinical setups. Any medication that has a larger therapeutic index is generally preferred. Another important reason why second generation antipsychotics have taken over the first generation antipsychotic is because of the differential risk towards tardive dyskinesia. Now, coming to the next question is, okay, if first and second generations are more or less comparable, if you put every antipsychotic together in a group, are all antipsychotics equal in efficacy, or there is some kind of efficacy gradation? So there has been a recent research, especially in the form of network analysis, which has suggested perhaps there could be a graded efficacy. So this is the network plot of the study that was published in the year 2019, which basically summarized certain medications like clozapine, amisulpride. Of course, zotapine is not so much of use. There are very few studies. Olanzapine and risperidone were significantly more efficacious for the primary outcome. And in this particular network meta-analysis, amisulpride was found to be the most efficacious antipsychotic. So this is the kind of efficacy grading with we know that the clozapine is something with all the studies showing significant positive support for this molecule stands much ahead of most other molecules. And if you look at the positive symptoms, this is the kind of gradation this particular network meta-analysis gives. And with respect to negative symptoms, there seems to be a benefit with clozapine, and especially amisulpride is a noteworthy molecule which is worth considering. And I'll be mentioning in the later part the role for medications like cariprazine. And if you look at depressive symptoms, again, clozapine, amisulpride, and olanzapine, they score an aripiprazole fare better than most other antipsychotics. And there are also other metrics like social functioning. Of course, these are relatively complex measures which may vary depending upon the study design and the nature of instruments that you use to assess that particular parameter. Of course, coming to the side effects, we know QTC prolongation is a major concern. Medications like lurasidone and aripiprazole are relatively safer in comparison to medications like amisulpride, ziprasidone, and iloperidone. Now, there is also some recent interesting summary of this network meta-analysis. The most recent one is published in the World Psychiatry last year, where they have looked at two types of network plots. One looking at the relapse, in which they have utilized certain advanced metrics to quantify and grade the antipsychotics. And the recent meta-analysis, especially looking at the risk for relapse, suggests medications like amisulpride oral and olanzapine oral. And there are also studies that have summarized aripiprazole long-acting to be of high confidence molecules. And we have a range of other molecules that come lower down as the next levels of confidence. And this particular study, I was quite surprised to see the risperidone getting lower down in its rating. The second component of the study looked at the tolerability. The confidence level in terms of better tolerability, aripiprazole, and then at the next level, we have olanzapine and risperidone coming in that kind of order. Whereas most other molecules go into the very low confidence level. So this is the kind of evidence that is existing with respect to the graded efficacy or the graded benefit versus risk with respect to several of the antipsychotics. Another important line of evidence that is emerging is in terms of the understanding related to the onset of antipsychotic action. The dogma is that we need much longer time, usually about 4 to 6 weeks, to identify a noteworthy response to antipsychotic medication. But more and more research suggests that the onset of action could be much early. To that extent, the maximum symptom improvement may be happening within even the first week of treatment with antipsychotics. So there are very interesting overviews and good summaries to support this early onset hypothesis, which in fact has influenced the recent recommendation by certain prescribing guidelines like Maudsley, which I'll be revisiting in the later part of the slide. And also, there is evidence to suggest lack of early improvement predicts non-response. So basically, compelled by this observation, there is a tendency to recommend the adequate duration of initial observation with antipsychotics to be 2 to 3 weeks, so which we'll be discussing a little later. And there is also some interesting proposals in which we can use a scale like clinical global impression in a busy clinical setting. And some of these scores could be equated to what may be obtained by a comprehensive BPRS or PANSS, both in terms of the severity assessment as well as improvement rating. So this is an area which can be considered to look at developing real-world databases, especially in a setup like ours, across various centers where we can generate more and more data that will be relevant for our population. So given all these kinds of evidences, how would one look at optimization of treatment in first episode early course of schizophrenia? So one interesting aspect in terms of research design is to look at what happens to first episode schizophrenia patients when they are treated in a relatively naturalistic setting. So this is one of the first reports of that kind published from the CAMH Toronto that has looked at a serial treatment with medications like olanzapine as the first line antipsychotic versus risperidone. And then what happens when they are then shifted to clozapine. So the study showed that in the trial 1, 74% of individuals responded with rates significantly higher for olanzapine. And with trial 2, the second trial, the response drops down significantly. And then when we shift these patients to clozapine, again, the response rate increases. So essentially, it suggests that in the early course of treatment, there is a good response, which borders closer to 75%. And this has also opened up a question, when we are looking at a trial with second antipsychotic, which just gives 16% incremental benefit, and why should we not consider a clozapine as the second line? So that is one lead question that is coming up, and which has been examined more systematically in this OPTIMIZE trial. Again, the design is somewhat similar to what was retrospectively done in the earlier studies, but here in OPTIMIZE, it's a 3-phase switching study. In a prospective way, people were treated with initial open label intervention with amisulpride, and then they were also shifted to a double-blind randomization of amisulpride versus olanzapine, and then followed with clozapine. So in the patients that completed all the 3 trials, cumulative remission at the end of 22 weeks is again similar to what was reported by Ejid and colleagues many years earlier. So OPTIMIZE is one study which has again thrown open the question whether clozapine could be considered as a second-line antipsychotic. So this is as far as the first line treatment in terms of the early phase approach towards treating schizophrenia patients is concerned. So once a patient responds to antipsychotic, so what is the status with respect to relapse prevention in terms of oral antipsychotics versus long-acting injectables? So there are initial studies that are summarized that results in mirror image studies of patients eligible for the clinical use of LAAs. So it showed strong superiority of long-acting injectables compared to oral antipsychotics. So there are more and more evidences that are being built towards recommendation that long-acting injectables perhaps should be tried much earlier. And in that context, there are studies that have naturally looked at what is the efficacy profile of, say, older versus newer depot. The earlier summaries, the one that were published about a decade before, actually showed that there may not be much difference between the older versus newer. Of course, at that time, newer antipsychotic depots were much lesser than older. And in those studies, depot haloperidol and flufenazine had the greatest effects. And in one of the earliest studies that have looked at a head-on comparison between paliperidone palmitate versus haloperidol, the conclusion was that in adults with schizophrenia or schizoaffective disorder, use of paliperidone palmitate versus haloperidol did not result in a statistically significant difference. So this was one of the initial observation. But over the course of past decade, there has been a gradual increase in the use of second generation depot, primarily because of the reasons of the same therapeutic index and the risk for tardive dyskinesia, which is disproportionately more with first generation antipsychotics. However, we are also aware the major side effect with the second generation antipsychotics, that is metabolic syndrome. Coming to the maintenance phase related views, for maintenance therapy, the natural question would be that what would be an ideal dose? So some of the broad guidelines suggest the antipsychotic dose should be reduced gradually to the possible effective dose at the lowest level. But generally, the target dose should not be lower than half of the effective dose during the acute phase. Nonetheless, in our clinical setting, including some of the studies that we reported from NIMHANS, what has been observed is that the mean antipsychotic dose used during the maintenance treatment was approximately 30% lower than the dose that was used during the acute phase. And importantly, in our observation, we found that about 40% of the subjects maintained well with a dose less than the recommended therapeutic range. So this is another important area which is gaining more and more attention, whether we are using more than required dose to treat patients in the longer term. So this is becoming an important area of interest, especially with the re-emergence of concepts like dopamine supersensitivity psychosis. Now, in patients that are maintaining well with antipsychotic, when would we consider a long-term or possibly lifelong treatment? Those patients where there is a significant risk for aggression and they have a risk for suicide, and history-wise, there is a relapse even with minimal dose reduction, presence of residual symptoms, and significant adverse impact of relapse given that particular individual, and person-specific situation in which relapse is unthinkable. So these are certain instances where we would look at a longer-term treatment with antipsychotics. Perhaps one may want to look at a lifelong prescription. Is there a possibility of stopping antipsychotics? If so, when? The recommendation is that in functional patients with the symptoms remission, one may consider stopping antipsychotic in the context of first episode schizophrenia after about 1 to 2 years of remission. In multi-episode schizophrenia, perhaps 3 to 5 years of remission with good functionality is an instance one may want to consider, but we need to carefully consider several of the factors. Of course, many of these factors have been emphasized by Dr. Grover's guideline. And some of the useful questions again have been addressed in the previous slides, as well as the outline that is given by the existing guidelines of IPS. Now, when we are stopping antipsychotic, how should we withdraw? The general guideline is it should be as much gradual, and withdrawal of oral treatment may also lead to discontinuation symptoms. So that is something we need to look at, so that should not be, for instance, insomnia should not be mistaken for early warning symptoms of relapse. And there are studies that show the relapse rate in the first 6 months after abrupt withdrawal is double that seen after gradual withdrawal. So what is a gradual withdrawal? A slower taper down over at least 3 weeks for oral antipsychotics, and a more gradual withdrawal is perhaps preferable. 25% dose reduction every 4 to 8 weeks. So this is something which perhaps is worth considering in the context of withdrawing and stopping antipsychotic. A brief note about the treatment-resistant schizophrenia. We know 30% of schizophrenia are resistant to at least 2 or more antipsychotics other than clozapine. And there has been a lot of work and redefinition of the treatment-resistant schizophrenia in terms of making some of the parameters more objective. Especially the TRIP guidelines have given a lot of clarity on definition of treatment response. And there are also some recommendation to consider long-acting injectable treatment trial before deciding a patient to have treatment resistance. So in that context, there are other interesting research that suggests that the treatment resistance could be of different types. It could be early onset, medium-term onset, or late onset. And very interestingly, people that have treatment resistance perhaps are the ones which are slightly different from the classical increased dopamine synthesis disorder. In the sense, like in this particular study, they have looked at dopamine synthesis capacity in patients with treatment-resistant schizophrenia. So significantly increased dopamine synthesis capacity was found in responders relative to those patients that had treatment resistance. So this made some of the researchers to postulate hyperdopaminergic and normodopaminergic concepts. But what is important from a clinical perspective is a particular research that has looked at the trajectory of treatment resistant. If you look at the entirety of treatment resistant patients, 70% of them actually met an early resistant kind of subgroup definition, in which the criteria for treatment resistance was there right from the beginning, and they did not experience a symptomatic remission from the time of first presentation. So this is something which is very, very important, especially because of the chances towards optimal utilization of clozapine. But before deciding somebody as treatment resistant, we should ensure they are not pseudo-resistant in terms of non-adherence or concomitant substance abuse, other medical disorders or medications that may affect the antipsychotic pharmacokinetics and pharmacodynamics, adverse or detrimental psychosocial condition. And there is also renewed interest in this concept of dopamine supersensitivity psychosis, which may be presenting like a treatment-resistant schizophrenia, especially in the context of if you see a rebound psychosis and tolerance to antipsychotic effect, and the tardive dyskinesia, appearing especially at the time of withdrawal or dose reduction. So in such patients, there are studies that support the utility of long-acting injectables at a carefully titrated dose, and there is a potential role for clozapine, and there is also a suggestion that medications like quetiapine, aripiprazole, and adjuvant valproate may have a prevention role. Coming to the related concept of treatment resistance versus resistant to treatment, this is essentially people that take medications, but the bioavailability is poor, because of which the symptoms persist. So such studies have shown the role for plasma monitoring in people that are treated with antipsychotics. And of course, I just want to briefly touch upon the increasing and repeated support for the superiority of clozapine in terms of the efficacy. The one set of summary I presented in the earlier part of this talk. And this is another set of evidence which looked at the real world effectiveness of antipsychotic treatment, in which oral clozapine stood the first. And there are many benefits of clozapine. Although we use clozapine in people that are more severely ill, clozapine's use was associated with reduced hospitalization, all-cause discontinuation of treatment, and reduced overall symptoms. Now, this brings us to the question, if clozapine is such a wonderful molecule, there is one initial provocative line of thinking that examined whether clozapine can be used as a first-line molecule. But studies that have used clozapine as a first-line antipsychotic drug did not show definitive evidence for superior clinical benefits. So it is highly likely when clozapine research is done, these are in a selected subsample of patients who are already likely to respond clozapine better than other medications. So what is challenging is to identify a reliable and clinically implementable biomarker that can differentially predict who will respond to clozapine and who will not. And there are also recent meta-analysis that suggest there may be a case to consider clozapine as a second-line antipsychotic medication. But if you look at the sequential antipsychotic trial evidence, it is noteworthy that since there is a possibility of 1 in 3 first episode patients achieving remission with a non-clozapine antipsychotic during the second trial, one may still want to adhere to the requirement of 2 adequate antipsychotic trials before we look at clozapine. However, there could be very selective instances where one may want to preemptively start clozapine as a second line, especially in people that are having a shorter duration of illness, very high baseline symptoms, and higher functioning in the year before clozapine initiation, and coexistent affective symptoms, which goes with high risk for suicide, persistent or severe aggression, greater risk for extrapyramidal side effect, and severe polydipsia, And there is also some emerging evidence to suggest cannabis dependence. So if we have such a patient who has not shown even minimal response to first line, one of the preferred antipsychotics, say for instance, it could be risperidone or amisulpride or olanzapine, in very select instances with appropriate informed consent, one may want to think in terms of clozapine as the second line if there are many such compelling factors. So essentially, if we look at the role of clozapine, the predominant recommendation is that we need to bring forward the utility of clozapine in terms of its prescription. And more and more studies, including the ones that were done in our setting, has shown inordinate delay in initiating clozapine. And 2.8 years was the cutoff, which was shown by one of the study, which tipped the balance between good response versus poor response to clozapine. So the predominant recommendation is to look at once two effective antipsychotic trials are completed, preemptively, we should look at initiating clozapine. And in this context, some of the research that were done from NIMHANS by my colleagues Suhas and Vijay, they had shown perhaps the Indian patients may not require as much clozapine as the Western counterpart. In the sense, the clozapine dose required for a therapeutic serum level was as low as 140 milligram. And in male smokers, this was again around 250, that is 238 milligram. And in female non-smoker, it is much lesser than the average dose. So this is something which needs more research, and perhaps we may consider utilizing clozapine in our population at a lower range of the dose than higher. So in that context, there are some interesting recommendations. One is utilizing medications like fluoxamine along with clozapine to reduce the metabolic side effects of clozapine, especially because utilizing co-prescribing fluoxamine increases the clozapine to norclozapine ratio, thereby the metabolic side effects could be less. And this has been shown by one randomized double-blind placebo-controlled study that adjunctive fluoxamine can have beneficial effects on the metabolic side effects. And there are also certain repurposed medication avenues. Say, for instance, beta-histine is a molecule which can actually help in weight reduction for people that are treated with clozapine. And we have some favorable experiences in terms of prescribing beta-histine. I'm not getting into the literature on metformin, which is very well established, and there is more than sufficient evidence to use metformin to handle the metabolic side effects of clozapine. Coming to the last few slides of my presentation, what to do when clozapine fails? This is a very challenging area. In terms of antipsychotic co-prescription, there is role for amisulpride, risperidone, and aripiprazole, but add-on electroconvulsive therapy may be a promising option. So this is something which we are examining in a much controlled design in an ongoing study. And there is also emerging role for other neuromodulatory intervention. And in that context, there are also interesting avenues in terms of using molecules that will modulate the other pathways like adenosine pathway in people that are treatment-resistant schizophrenia. We have reported one patient who was not responding to clozapine, ECT, any other antipsychotic, multiple different trials, but with add-on allopurinol, there has been a remarkable improvement. And also there is increasing interest in using interventions like transcranial electrical stimulation, both conventional as well as there is a recent advances in terms of using high definition transcranial electrical stimulation. And of course, there is also a role for transcranial magnetic stimulation. Coming to the negative symptoms, it's a much, much bigger challenge. There is a role for medications like amisulpride, olanzapine, and cariprazine. And negative symptoms is something which has to be handled carefully in terms of avoiding the secondary negative symptoms. and utilizing some of these molecules. And there are also roles for using add-on SSRI, using medications like minocycline. Some of the research study that we have done at NIMHANS show utility of add-on yoga therapy to be helpful in the treatment of negative symptoms. Coming to the last couple of slides in terms of what are all the outstanding questions and the future directions. This is a recently published systematic review of schizophrenia clinical practice guidelines by Dr. Christoph Correll and colleagues. They have reviewed 19 clinical practice guidelines and concluded that all guidelines recommend antipsychotic monotherapy, but they do not agree on a preferred antipsychotic. There are no explicit recommendation on the maximum duration of maintenance therapy. Also, in terms of the recommendation of long-acting injectable, whether it can be used earlier in the course of the illness or one has to wait till later part or non-header patient, there is a difference in the opinion. So some of the important outstanding clinical questions are, how long should patient remain on antipsychotic therapy after a first episode or during maintenance therapy? What is the most appropriate treatment for negative symptoms? And the specific recommendation with respect to the use of long-acting injectable antipsychotic medication. Another interesting study that was published this month, which was quite intriguing. This is something which is published in the American Journal of Psychiatry, which is bringing up another dimension to the treatment of schizophrenia in terms of a compelling outstanding question, whether there is a role for antipsychotic polypharmacy. So this is one of the largest data that I have come across. This is from a Finnish nationwide inpatient care register. This study concluded that among patients who had used both monotherapy and polypharmacy, that is schizophrenia patient, the risk of non-psychiatric hospitalization was significantly lower during polypharmacy. The risk of cardiovascular hospitalization was significantly lower. So this is something which is a very intriguing finding compared to what has been published in most other literature till now. But it is perhaps something which is in sync with a larger practice that we have in challenging set of patients. So this is one conclusion that is coming out with from a study that was published this month, where the results show antipsychotic monotherapy is not associated with a lower risk of hospitalization for severe physical health problems when compared with antipsychotic polypharmacy. So these authors, they come up with a very significant note that treatment guidelines should not encourage use of monotherapy instead of antipsychotic polypharmacy. So this is an important area which needs more debate and research. And I have just summarized some of the points which I made in the previous slides, and given the time limit, I will perhaps just emphasize one or two points. Like the metformin is something which I just briefly mentioned, and I didn't touch too much upon the side effect. The only point I just want to emphasize is, based on the early onset hypothesis, recent recommendations suggest that if there is any improvement that happens in the first 2 to 3 weeks, some substantial improvement happens, then it is worth waiting for a longer period with the first antipsychotic. But if there is no effect by first 2 to 3 weeks, perhaps one should look at changing the dose. But more than changing the dose, there is evidence to suggest changing the drug could be a useful option. So this is an important newer line of recommendation which is coming. And apart from that, most of the other recommendation that is published in the 2020 Maudsley guideline is in line with what Grover and colleagues have published a few years before. And this is just outline of the metabolic side effect treatment. I do not want to spend more time, and perhaps with this I will stop, and I thank my colleagues who work with me for all the research that we have been doing, and I thank the organizer for this opportunity. Thank you, sir.
Thank you, Professor Venkat. that was so comprehensive yet so easy. No, it seemed to be becoming so easy and so practical. And I think, say, participants must have got a lot of benefit out of your wisdom. Now, say, Professor Dr. Sandeep Grover, sir, your views and your comments. Say, you have to unmute yourself. No, we have not been able to unmute you.
No, you should be able now. I have checked the
Okay.
mark.
Yeah. Am I audible now?
Yes, you are, sir.
Yes, yes.
Yeah. Thank you, Venkat, for that comprehensive talk. And I think what Dr. Venkat has highlighted at how we are moving in the management of schizophrenia. And if I look at the post CPG of schizophrenia from IPS, one of the major area of research has been clozapine. That a lot of things have come up with regard to the definition of TRS, how we need to approach TRS, and how we should initiate clozapine as early as possible. So that's something which we all need to learn, that in the recent years across the world, there is a lot of emphasis on using clozapine as early as possible, but not at the first episode. And if somebody has treatment resistance, right at the early, don't delay use of clozapine. That's what Dr. Venkat has highlighted, and that's very, very important from a person who is dealing with schizophrenia, and he knows that how important it is to start clozapine in time. But the other thing which IPS guidelines recommend, that at present, other than clozapine, no antipsychotic is superior to the other. So in the Indian context, as the guideline highlights, that we need to take the cost issue and other issues into account while choosing an antipsychotic: cost, side effects, and the kind of supervision which is available, not available. In the Indian context, again, the guidelines, when we compare with other guidelines, have given this liberty to use ECT much before the clozapine resistance comes in. That's something which we differ from across the world, although our clinical experience also suggests that ECT can be given much before. Sometimes we all end up using ECT in the first episode also. So that is where the IPS guidelines have highlighted that because of the Indian experience, but no Western literature is supporting that. So that's where we need to understand that we need to generate more data here, because we have less stigma with use of ECT here. And use of ECT in clozapine resistant schizophrenia is something, again, except for one randomized controlled trial, other open label studies have come from India, in fact, if you look at that. So from that point of view, the research in the area of schizophrenia, as researchers, we have contributed significantly to understanding some of the aspects of schizophrenia. So what we need to understand, that at present, we are still at the same level. Although newer antipsychotics are coming into the market, we have to take the cost and the side effect profile for choosing an antipsychotic. So with this, I'll stop for the participation.
Thank you, Dr. Sandeep. And say, there are so many questions being raised. There are so many, comments in the chat box are being raised. One comment for you, Professor Venkat, is a comprehensive explanation for practical application, practical tips, and you have given comprehensive scientific explanation for, say, treatment in the field of the schizophrenia. Now, Dr. Shahul, do we have few questions?
Yeah, I will raise some of them. There have been lots of questions. Dr. Venkat, it was a very lucid presentation. Dr. Sudhir Bhave wants to know what is your personal experience with amisulpride for negative symptoms?
Yeah, I think this is a very important question. In people that are having negative symptoms, where one can rule out the secondary negative symptom as well as other nutritional reasons and the many other factors of secondary negative symptoms, I found amisulpride to be very useful, especially in a lower dose range. Lower dose range, I mentioned somewhere between 200 to 300. One important determinant would be early course of schizophrenia. So my experience of positive effect with amisulpride in the context of negative symptoms in the early course, usually within the first 5 years of illness.
Okay, thank you. There
In
is
the same vein, Dr. Akhtar has asked for say use of amisulpride for cognitive improvement.
Yes, so if you look at the cognitive deficit, that is a big challenge. I haven't touched that in any of my slides. I consciously avoided that because there is no compelling evidence for any of the medications to distinctively improve the persistent cognitive deficits in schizophrenia. So most often it will be related to removal of several of the factors. It could be sometimes high dose antipsychotics or the anticholinergics and so on and so forth. And the second important aspect is with respect to some of the coexistent nutritional deficiencies that are influencing the cognitive deficits. So what we find with my personal, of course, a limited experience is the utility of adaptive lifestyle, especially the physical exercises. And there are also instances where if I could make some of the people do successfully yoga, I found cognitive deficits to become better. And transcranial direct current stimulation is another intervention in which we have found some improvement. Whereas with respect to the medications, it is mixed. I could not come across anything very definitive compared to the other options.
Okay, thank you. There is one question from Dr. Sagar Hasija. When do we consider reducing the dose after the acute phase treatment?
Yes, so this is exactly one of the outstanding question, which is put up in the recent systematic review. So it is again it has to be highly personalized. The approach I adopt is the rapidity of the improvement with antipsychotic medication and the dose with which the person has started showing the response and the totality of improvement. If these are very good, I know there are instances one may want to even consider reducing the dose of the medication, especially if there are disabling side effects. It could be as early within 4 weeks. There are people where if these aspects are not there in terms of the onset has been quite delayed, we had to use second antipsychotic, or we had to kind of hospitalize a person and then look at adding ECT and reaching the response. Maybe we need to wait at least for about 6 months before reducing the dose, unless otherwise there are disabling side effects. In the context of disabling side effects also, the difference between the first set of excellent responders versus responders but not so excellent, we have to be carefully considering the possibility of shifting to some other antipsychotic which may not have much side effects. Say, for instance, it could be a shift from something like olanzapine to aripiprazole. So this is an area where we need more work because there is no definitive way of predicting who will require longer and who will require shorter term. I think it kind of comes with more and more experience. I'm sure many of the teachers here will be able to give much more clarity on this. Thank you.
Mr. Venkat, Dr. Mazid has shared a question, and he shared this question which other persons have also in their mind. How many antipsychotics can be combined in treatment-resistant schizophrenia?
That is treatment-resistant schizophrenia means, is it a treatment-resistant situation where clozapine has not been tried?
Dr. Mazid?
I think
yeah.
for...
yeah.
Okay, so yeah. So right now, with the existing evidence, barring some of the studies along the lines of Finnish publication that I presented at the end of the presentation, there is no compelling rationale for combining two antipsychotics, unless otherwise there is a select instance where we see, like there is a patient who has not responded excellent to risperidone, partial response. I add olanzapine, there is a good response. Then I start reducing risperidone, find the response to kind of wean off. And then I try it at least for a couple of times and ensure the combination works. So in such instances, with careful recording, we use combined antipsychotic treatment. But for such select instances, there is no recommendation to use more than one antipsychotic in the context of treatment resistance before clozapine. So,
okay, thank you. In your presentation, you said that like one of the factors that favor a response to clozapine is comorbid cannabis use. So one of the participants wants to know what is the mechanism, how clozapine works in when there is cannabis use.
Okay, so this is a line of research which is coming up where they have seen when people that are using cannabis along with schizophrenia, when they were given clozapine, the cannabis use decreases. So that is number one. It is perhaps related to the kind of the endocannabinoid related signaling pathways which gets differentially influenced by clozapine vis-a-vis other molecules. So the related mechanism has been described. It is again a speculation where we need more research. This is a paper that has appeared in neuropsychopharmacology. Maybe I'm happy to share that paper with this faculty. I think this is an excellent question. I think this is an area. So these kinds of research leads will help us to kind of personalize the choice of clozapine and look at people that may respond preferentially to clozapine than others. Thank you.
Dr. Vipul, you will ask them.
No, Dr. Saul, please carry.
Okay. There are two questions on cariprazine. One is from Dr. Ashok about when to prefer that in schizophrenia. And there is another question about its role in negative symptoms from Dr. Pankaj.
Okay. Yeah, a quick answer for this would be that if you look at most of the guidelines, there is a recent guideline that is published by the Polish group from Poland, where they recommend cariprazine as the first line antipsychotic in negative symptoms. So perhaps this is related to the adaptive dopaminergic influence, not so much of dopamine antagonism with cariprazine compared to many other antipsychotics. So this is the quick answer I could give. So, and this is one outstanding question which is emphasized in Correll's review. What would be the preferred antipsychotic in negative symptoms? So the molecules are cariprazine, amisulpride. Of course, I also see a question, cariprazine versus amisulpride for negative symptom. I'm not aware of any head-to-head comparison in this context. Thank you.
Also about cariprazine, there is one question from Dr. Majid. The cariprazine and tongue fasciculation or perioral movements as acute side effects. Any thoughts?
Okay. I have not come across and I am not aware of it. I do not know. Maybe any other faculty could chip in with respect to this question. Yeah, this is something which I will read and try to understand. Maybe if anybody else is aware, they can add. Thank
Dr. Vidushi Singh. Yeah, please, sir.
Sorry if I can come in, Dr. Shahul.
Yeah.
Actually, I experienced the same thing in two patients of extremes of age. One was around 17 years old, BTech student who developed fasciculation, classically tongue fasciculation, she would talk about. I had gone from 1.5 to 3 milligrams and she started with it. So once I decreased the dose, after 1 week, she was absolutely fine with 1.5. Same happened with an elderly person who had bipolar affective disorder. So he started with 1.5, he was doing well, went to 3 milligrams, and he started with fasciculation and perioral movements. That was two observations only. It could not be generalized. It's just an observation I have seen in two of my papers.
Thank you. Thank you, sir. I think this is something I'll try to read about.
Thank you, Dr. Majid. The next question is from Dr. Vidushi Singh. Why does polydipsia occur in schizophrenia, and how does clozapine help in the situation?
Right. I think this is another talk altogether, but the reason for polydipsia is something which is again linked to the reward processing pathways and dopamine abnormalities. And the kind of dopamine abnormality that is associated with polydipsia is very different from what we see in the classical presentation in the acute phase. The reason why clozapine could be helping is mainly because it's a differential modulation of the dopamine receptor, because it's not a persistent antagonist. It's more of a transient antagonist. So that is one reason. The second reason is perhaps it could be related to the uniqueness of clozapine in terms of its combination with many other receptor profile. Yeah, but this is a clinically important situation. And there are polydipsia that have been shown to happen with many other antipsychotic. And systematic studies in this area, they are really limited, and they show an utility for clozapine. One other view is that perhaps polydipsia may also co-occur in set of patients who are likely to be treatment resistant. So this is another view. Perhaps that's why the differential benefit of clozapine is very evident in this subset of population. Thank you.
Thank you. Another question is about the management of OC symptoms in schizophrenia.
Okay, so if the OC symptoms, obsessive compulsive symptoms, are antipsychotic related, antipsychotic induced, then the first approach would be, if possible, consider dose reduction of antipsychotic. If not possible, then the treatment would be like add-on SSRIs. The only caution is, suppose if somebody is on clozapine and having antipsychotic induced or clozapine induced obsessive compulsive symptom, we need to be very careful while adding medication like fluoxamine, because the clozapine levels can increase disproportionately. With fluoxetine also same situation can happen. So alternatives like escitalopram may be preferred.
Thank you.
Dr. R.K. Sharma has written a question. So I will try to reframe it. He says that in say our rapidly growing research era in schizophrenia, clozapine seems to be the only hero. Are there any other heroes?
Yeah, it is undisputed. But there is another way of looking at it. If we see the utility of clozapine in drug-naive patients, it's as good as chlorpromazine. So the other way of looking at it is that perhaps for testing clozapine, we have a pitch in terms of cricket pitch, which is favorable to the batsman, something like that. So that's an alternative view. But having said that, the kind of improvement that we see with clozapine is distinctly different, but in a subset of patients. So one can have these two kinds of opinion, mainly because I'm trying to think the second line, mainly because clozapine comes with lots and lots of adverse effect risk.
Shahul, next question.
Yeah, thank you. There is a question from Dr. Humaid. Especially when we are shifting to clozapine for treatment-resistant schizophrenia, how to taper off the drugs that are being currently used?
Yeah, this is a very important question. I think when we are starting clozapine, we need to see the profile of the antipsychotic the person is being treated with. Say, for instance, if the present antipsychotic is something like amisulpride, the profile of amisulpride versus clozapine are distinctly different. So it is highly unlikely that there will be an additive risk of side effects. So in such situation, unless otherwise QTC prolongation is an issue, I would probably stick on to amisulpride for quite some time till I build a dose of clozapine that shows some initial response. On the other hand, if you are handling a patient who's being treated with something like olanzapine or quetiapine with already significant sedation and other anticholinergic side effect, perhaps I will try to reduce the dose faster. But if there is a worsening of psychosis, there is an option to use adjuvant benzodiazepines for the transient period. So essentially, it will be decided by two important factors. One is the receptor match versus mismatch profile between two antipsychotics. The second will be the amount of clinical response the patient has had with the existing antipsychotic. That is, those patients where there has been a partial but a noteworthy response, it is better to wait for some time before reducing the previous molecule. And always the approach will be a cross taper.
Thank you. Dr. Farhana wants to know how to treat depersonalization and derealization in schizophrenia.
Right. I think this is something which is kind of gaining more and more importance. That is the role of so-called basic symptoms and experiential component and self-related abnormalities in schizophrenia. So many a time, such symptoms may respond well with an add-on SSRI. So in my limited experience in some of these patients, I have found add-on SSRIs to help. And sometimes if these symptoms are existing, it is also worth exploring for any other visual phenomena. It need not be visual hallucinations. It could be visual distortions. So in such patients, there is a role for adding neuromodulatory interventions, which we are finding it quite helpful, or set of medications which have serotonergic modulation. Say, for instance, many of the newer antipsychotics, in addition to the D2 antagonism, they also have serotonergic effect. So such molecules could be of help. So perhaps if such patients are treated with some pure dopamine modulator like amisulpiride, it is worth considering medications like, say, for instance, the ones which are available recently, like something like risperidone or olanzapine and things of that sort.
Thank you. Related to what you just now told about adding SSRIs, there is a question from Dr. Raja about how about adding fluoxetine or paroxetine just to increase the levels of clozapine?
Yeah, I mentioned it very briefly, and this can be attempted in the early phase of clozapine treatment, especially in people who are at higher risk for metabolic side effects, preferably with clozapine level monitoring. So we are finding this combination useful in a select set of patients where if they are at a very high risk for metabolic side effects in terms of pre-existing weight gain with other molecules, or even with a very low dose of clozapine, we start seeing early features of metabolic side effect. One clinically useful indication will be a significant increase in appetite, which can happen within the first and second dose of clozapine.
I would like to add to that, add to the question actually. Like what you said was, if you add fluoxetine, the ratio of the norclozapine and clozapine changes, and because of that, the metabolic side effects come down. This fluoxetine, paroxetine, whether they act in the same manner or whether they act by blocking the CYP.
They actually block. More than paroxetine, it is fluoxetine. So it blocks the conversion to conversion of clozapine to norclozapine.
Okay. That way the ratio changes.
Yes.
Okay. Thank you. Then one question is about the role of sodium benzoate and magnesium taurate in schizophrenia.
Okay, so the sodium benzoate study became very attractive after the biological psychiatry publication, but over the past many years, we have actually tried sodium benzoate in many patients. We have not found it to be helpful. With respect to the magnesium compound, I do not have any idea, sir.
Okay, thank you. Then again, another question is, in patients who are non-responders or partial responders to clozapine, what agents to use for augmentation? It is from Dr. Mishra.
Right. So the topmost choice will be the electroconvulsive therapy, if it is. Otherwise, the option will be, I would go for amisulpiride as the augmentation, first level. Then comes risperidone or aripiprazole.
Okay, thank you. One question from Dr. Gulzar. A patient on clozapine suddenly develops neutropenia, absolute neutrophil count of 1,500. So how to manage? We abruptly stop or switch to another? This is the doubt.
Yeah. So if the neutropenia is significant, which can lead to agranulocytosis, there are very clear-cut guidelines. So whenever it drops to the level of agranulocytosis, it's life-threatening. So we have to resort to abrupt stopping of clozapine. And most often this will happen in the initial few weeks when we build the dose of clozapine. So invariably, I would say in 9 out of 10 patients whom I have come across the leukocyte leukopenia related side effect, it has happened in the dose building period itself. So given that kind of situation, many a time abruptly stopping clozapine has never been a challenge, but there are patients where they have been maintaining well and then they developed neutropenia. We had to stop clozapine and it has to be abrupt.
Thank you. 3 more questions as of now. One is, about the use of blonanzarin in schizophrenia?
I have limited experience of using blonanzarin. I wouldn't say it is distinctively superior to any other antipsychotic. I may also be biased mainly because the kind of patients that come to NIMHANS are the ones they have been tried earlier on blonanzarin, they don't respond, then they come. So that's how it is. But my experience with using blonanzarin as a first-line agent is very limited, sir. For some reason, we have not been, using this molecule more like in many other settings.
Thank you. One question from Dr. Saurabh Kundu. What about the management of resistant auditory hallucinations?
Yes. So if the auditory hallucinations are resistant, they generally respond to neuromodulatory interventions. Especially if clozapine has been tried. So we can either use electroconvulsive therapy, or if there is an availability, RTMS or TDCS. Both are options. And of course, we have the cognitive behavior therapy, especially if the resources permit.
Okay, thank you. Regarding to the earlier discussion about altering the clozapine or clozapine ratio using fluoxamine and all. Like we said that the metabolic side effects may come down, but are there any other adverse effects that may increase, and how to decide the risk-benefit ratio? This is from Dr. Saurabh Sundaresh.
The risk for adverse effect will be primarily due to the higher serum levels of clozapine. So that's why we have to be very, very careful. Say for instance, the studies that have looked at add-on fluoxamine to clozapine, they were used as low doses 100 milligram of clozapine with about 50 milligram of fluoxamine. So the risk for adverse effect will be more like the possibility of seizure, excessive sedation, and constipation, which are predominantly the higher clozapine level related side effects. So if we adopt a very careful and monitored approach, those side effects could be avoided.
Thank you. One question from Dr. Smita Ramdas about adding lithium for leukopenia.
So it can be used, especially if the levels of leukocyte drop doesn't amount to agranulocytosis. So we can actually try lithium in people where especially we have to monitor using the absolute neutrophil count and add on lithium. Especially we have used this kind of approach in select patients who have responded excellently with clozapine and have started showing some reduction in blood count, but not so much that agranulocytosis has developed. So in that period, add-on lithium is a useful option to try. There are also reports of, again, these are anecdotal and very few cases, add-on zinc is another option which can be examined in such patients.
Thank you. So one question is from Dr. Vindhya about the role of N-acetylcysteine in negative symptoms.
My personal experience-wise, I have not found it to be distinctly different, sir. We have used N-acetylcysteine quite extensively in several patients with negative symptoms. We have not found a remarkable benefit.
Thank you.
Dr. Khalil has written that there is a risk of clozapine related leukopenia drops to the same level after 1 year of clozapine as other antipsychotics?
Yes. So after the 1 year, the risk becomes much lesser, but I do not know data whether it is comparable to other antipsychotics, sir. But it drops much significantly. But
in that case, my question is that then after 1 year, how frequent should we be monitoring?
Yeah, so this is a clinically important question. Now guidelines have become more and more liberal in the sense like now people are moving away from monthly once monitoring, especially after the initial period. That initial period is not definitively defined, but about 1 year is a reasonable period. especially in resource limited setting, this may be considered. And that recommendation also came into effect in the context of COVID, when people had difficulty in going for frequent blood investigations.
Okay. So, Dr. Shahul, any more questions? Or
no, I think there are some more kind of repetitions or very basic or something.
Yes.
I think the questions are.
So then I would ask our chairperson, Dr. Ashish Srivastav, to give vote of thanks. Dr. Niklesh doesn't seem to be here. Is he here, Dr. Niklesh?
He is online.
Dr. Niklesh?
Ashish. Niklesh,
Yes,
I didn't see him.
Niklesh could not join.
He said he will be traveling.
I come back here. I come back. Yeah. I think Dr. Niklesh was supposed
Niklesh
to
is
travel.
online. One Niklesh is online. I don't know.
Niklesh is there?
Name is visible. Anyway, you can start. No need to waste it.
Yeah, I think it was a wonderful, learning session today. Dr. Venkatesh has made it simple. It's a lot of data. It's a lot of wonderful high-class data that he has presented today, very simplistically for us to gather few points, take home points. And, especially young PGs, we're practicing, a lot of pressure of practice from different directions will have more clarity on their practices. And our colleagues at this stage also, we need a lot to learn in nuances of management of schizophrenia, though it's, people say that it's the same old medications, what we do, but there are nuances which keep developing, and that's what we have learned today at this point at our practice level. Thank you, Dr. Venkat, for that. And I thank all the office bearers of IPS who have done. My team, Shahul as EC coordinator, Vipul, Niklesh, and thank you, Gaurav, for being there. I truly admit there is a medical emergency going on in my family, and I was preoccupied with this. So Gaurav has done a lot for me today. And I thank bottom of all, we had at a point of time 210 plus people attending it. And towards the discussion, I would say 150 people were there throughout the discussion. So it's been a good, encouraging start for all of us. Thank you, Dr. Venkat, for holding that. Thank you.
We'll request all the participants to be there for next series as well. Professor Venkat, Dr. Mazid, Dr. Sandeep, Professor Nimit Desai, and everyone, please be there in other series as well. We'll follow with the next.
Yeah.
Thank you.
Thank you. Thank you, everybody.
Thank you. Thank you, sir.